So first off, apologize to everyone who's hearing this exact talk for the second time today. My name's Eleanor Miller. I'm a nurse practitioner and I'm a VAD coordinator of the Swedish LVAD program. And Redden has been generous enough to invite me back to talk to you guys about VADs. We had done a quick talk about it over the summer with just a few folks, and then talked this morning, and now back for round two. So one thing, and I'll just pass, we can get this circulated, but first, has anyone worked with VAD patients before? Anyone else?
In terms of balloon pump?
It is, I would say, in the same family, but a different animal. Yeah. So thinking about mechanical circulatory support, balloon pump is definitely up there. VAD is more of a durable heart support pump, whereas a balloon pump would really just be for temporary use. And again, apologize, my slides were initially designed for the emergency department. I actually have a slide deck just for you guys that I'll send to Redden and can be circulated by email. But these those are for the folks.
I'm sorry.
That's okay. It worked so well for me this morning.
Sorry.
That's okay.
There.
Perfect. Okay, so just to sort of define terms, so LVAD is a durable heart pump that is surgically implanted directly into the left ventricle. So unlike the balloon pump, which is inserted sometimes at the bedside, sometimes in the cath lab, and is in there for just a number of days or hours, the ventricular assist device is inserted surgically by a sternotomy, sometimes thoracotomy, but usually sternotomy, and it can be in a patient for up to a number of years. It has a couple, and this is just sort of a good picture to give you a sense of how it fits in the patient. So right into the left ventricle there, it's cored in. The pump sort of sits in a pocket here, and then there's an anastomosis up to the aorta. So it really takes over the pumping function for the left ventricle. You bypass the aortic valve essentially, and instead of the left ventricle doing the work to get the blood into the aorta, the pump does the work. Who gets an LVAD? So these are really for the sickest CHF patients we have. It's specifically for people who have left heart failure. So if you think of your right heart and your left heart as being very similar, I said this morning if you gave me a quiz about renal anatomy and physiology, I'd fail at this point, so just a quick review on cardiac in case we're on the same wavelength there. But your right heart is really still doing its same job, functioning well, getting venous return, sending it to the lungs, blood comes from the lungs to the left heart into the left atrium. All of that is the same. It's just the left ventricle that's not functioning properly, and this is supporting that. So this is really for New York Heart Association Class 4 patients. Those are very sick CHF patients. These patients have all been on optimal medical therapy for 45 of the last 60 days, so we've given it our absolute best shot. We've really tried to tune them up as best we can. They're still doing really poorly. And at Swedish, we implant patients who are what's called destination therapy, meaning they are not candidates for heart transplants and they are getting a VAD as a final destination. I think maybe more commonly they were used in the past as bridge to transplant, so to sort of hold people over until they could get a heart transplant, but now we're seeing more and more that it's used as a destination. So reasons you might not be a heart transplant: advanced age, severe obesity, etc. So you guys kind of saw the pump as it went around, and I'm happy to stick around if you guys want to look at it more carefully afterwards. But basically, you've got the pump in here, which is this guy, obviously, and that is connecting, like I said, to the aorta. The pump very crucially relies on power. So it either uses battery power, which are those two heavy gray things, or AC power. So you can plug a patient into the wall, or they can walk around with two batteries. For you guys, I know that this is mostly inpatient dialysis we're talking about. So if you have a patient on 2 batteries and they're in the hospital, then those batteries will run down sequentially and last for about 14 hours. If they're just sitting around their hospital bed, they very well may be plugged into the wall, but there's really, for a patient in the hospital, no concern about them suddenly running out of power and then you're stuck holding the bag and all of a sudden you have a pump that's run out of power. That's really not something that will ever happen. If it does happen, and on the very off chance, this controller actually has a built-in backup battery, so you will never be in the situation where all of a sudden the pump stops and you don't know what to do about it. I think one last thing that's important, and this is less foreign to you guys than it is to some other non-cardiac groups of providers, is the drive line. So this isn't a port that you guys use or is accessible for anything else. This is really just a power cord. So the power cord is connected internally to the pump and is then tunneled out of the abdomen to connect to the controller, which connects to power. So this we just cover in a sterile dressing. For most patients, it's about once every 3 days to once every week. Patients are great at doing their own dressing. It's not something you'll have to fuss with or deal with at all. Just talking about batteries and power source here. This is, again, just sort of how it looks. We spoke about this briefly this morning, and I'm not sure how much detail is helpful, but basically you can see when you look at the controller, it's like a little computer. And it has a number of sort of data points that it can give you. It can tell you how fast the pump is running, how much power it's using, etc. There's also a number of alarms that can sound, probably won't, but can. But for you guys, the most important thing to know is when this little green circle light is on, your pump is running fine. Anytime that you're caring for an LVAD patient who needs dialysis, there will be someone in the room with you who knows how to triage alarms. So you really don't need to know alarms on the controller other than this green light means you're good, the pump is running just fine. If you ever are caring for a patient and you hear an alarm, just let me, if I'm there, or the nurse know. These patients are always at Cherry Hill in the CVICU at 4 East, and all the nurses there get really in-depth education about caring for these patients, so they're kind of like your best friend if you find yourself caring for them. More about alarms again, and this is just an example of sort of the level of detail that's available to you with the patient, with the bad patient anytime they're in the hospital about what the alarms mean, what to do about them, but it's not, you don't need to know that as much. Okay, so very important for you guys is this pump is a continuous pump, continuous flow pump, so it's not a pulsatile pump, and for most patients the aortic valve either doesn't open or it opens about once every 3rd beat, so these patients do not have a pulse, which can be very disorienting and quite weird for people, and that also means that we use a Doppler blood pressure instead of a cuff. Does anyone know how to take a Doppler blood pressure? We were kind of like 50-50 this morning. So it's very easy if you ever find yourself if we need to give dialysis to a bad patient. I could personally come down and walk you through how to do it. You will do it twice and then you'll be a pro. It's easy. The number that you get with a Doppler is, I think there's some debate between clinicians, but it's somewhere between a systolic pressure and a MAP. The pump itself is preload dependent and afterload sensitive, so we really have to be careful that we're controlling a patient's blood pressure really closely, and we aim for a MAP of 65 to 85, really no more than 85. Obviously you guys won't be responsible for that directly, but just something to think about when you're taking fluid off the patient. Another thing that's important is that they're all on warfarin and aspirin. The target INR is the same as a patient with atrial fibrillation 2 to 3, and they're usually on 81 or 365 of aspirin, sort of depending. Let's see what else we have. So this, again, I think is really obvious to you guys just in terms of using lines vacuum ports, but the drive line, the cord that comes out of the abdomen, just really important to maintain the integrity of that and make sure it's never kinked, never bent. It is susceptible to breaking. There is a backup line in there, but still we just want to be careful with that. Okay. Any questions so far? Yeah.
What is the left ventricle doing? Will they have this?
Well, that's a great question. I think it varies a lot patient to patient. So there is the theoretical possibility that a patient could recover left ventricular function on an LVAD. I think the statistics are about 5% of patients actually do. But for most patients, they still remain on their heart failure medications for the duration that they have the pump. So their LV function is just as bad as it was before they got the pump. So you still see people with, on echo, they have an ejection fraction of 10 to 15%, and they really can't tolerate being off the pump for very long. Not that we try. But yet there's not a lot of LV function, most of these people. And like I said, the aortic valve may not open at all, or it might open sort of sporadically. I think talk to different cardiologists, you get kind of different answers. Some cardiologists believe you just sew the aortic valve shut at the time of implant. Obviously, that is concerning. Maybe it might be thrombogenic, or you don't want any little funky things to form up there. Most people will just leave it alone. If there's like severe aortic insufficiency, they'll fix it at the time of implant, but for the most part, just doing just as poorly as it was before.
Just pumping along with little to no resistance.
Yeah, basically.
What's the assisted lead out?
So, I think the more helpful way to think about that is in terms of flow. So it can provide up to 10 liters of flow per minute. That does not correlate precisely with like a cardiac output. And it is not rate responsive in the way that some of the new pacemakers are. So if you get a patient who starts going back to exercise or is doing cardiac rehab and they're on the bike, it's not going to augment their flow for their demand, which I think probably future iterations of pumps it will. So it's a static number. But up to 10 liters of flow, and I think the baseline is like 4. And that varies a little bit depending on which brand of pump you have. So this is Abbott makes Thoratec, but they're bought by Abbott, makes this. This is the HeartMate 2. There's something called the HeartWare and now HeartMate 3. This is the one that we've been using. Just for simplicity's sake, we focus on one. Any other questions? Yeah.
In terms of dialysis,
Mm-hmm.
how much fluid are we able to take off if enough fluid is just around?
So that's a really good question. And I think the best answer is you just treat these patients like any other patient, any other heart failure patient, in terms of rate and amount of fluid to take off. I personally would love if we could get a protocol just so that everyone feels more comfortable specific to VAD patients. But there's no real special considerations that I'm aware of in terms of specific dialysis with VAD patients. Unless anyone knows something different, but I don't think so. Any other questions? Yeah.
So how carefully do you follow the weights on patients?
Very carefully.
So you set a target weight.
We treat them exactly like we treat other systolic heart failure patients. So we have a target weight for them to monitor at home. We tell them to call us if they gain more than 3 pounds or more in a day, 5 or 7 in a week. We have found that sometimes patients who get LVADs actually gain a lot of weight, but not from fluid, but because all of a sudden they feel much better, so they have an appetite. But we have one patient who we implanted her, she's very young, She did not meet transplant criteria because of her BMI was about 44. And since being implanted, she's done a great job, gone to cardiac rehab, and her BMI is now below 40, and she's being worked up for transplant. So it can go either way, but in terms of weights at home, it's the same as just for any heart failure patient. Anything else? Okay, so just a few more things before we wrap up. As you can imagine, nothing is without a hitch, and there are a lot of potential complications with LVADs. Almost every patient who gets an LVAD will be readmitted within a year of implant at least once. Because the pump itself is a foreign implant into the body, it can change the way that some of the clotting factors, specifically von Willebrand factor, functions. And so you do find that a lot of these patients get basically acquired von Willebrands where they bleed more easily. So there's a lot of GI bleeds and a lot of severe nosebleeds. We had a patient who had to have cautery in his nose because he was just losing so much blood from nosebleeds. And then on the other hand, they're also prone to embolic stroke, so we do need to keep them anticoagulated. So that is really a dilemma for all of these patients. There's obviously also a risk of infection because they have a line coming from out into out, and right-sided heart failure and ventricular arrhythmia. So there are a lot of potential complications. I think you'll find that these patients, from your perspective, are more stable than an unstable heart failure patient who doesn't have a VAD when you see them in the hospital. So, yeah, I think that's it.
How long have you been using these on patients?
Since February of this year, but they've been in use for a long, long time at other centers around the country, and we were talking this morning about most of the data in terms of survival with pumps. It's only been studied up to about 2 years, but there are centers, multiple centers, that have had patients alive on VADs for up to 10 years. And the data for them is pretty compelling. If you look at a patient who has NYHA class 4 heart failure managed on just optimal medical therapy versus someone with an LVAD, a continuous flow LVAD like this one, the survival at 1 year is about 20% versus 80%. So it's a really big deal for some of these people. There obviously are lifestyle restraints. You can't ever go swimming again. Showers, you have to put all your stuff in a waterproof bag because obviously you're connected to batteries. But other than that, they can really live a pretty normal life. And they look, you wouldn't necessarily recognize them just walking around. So, yeah. And then, like I said, we don't have any patients that I anticipate will need this in the near future. But if you do care for these patients, we are very available. I'm at Cherry Hill. The nurses over there, charge nurses, floor nurses, unit nurses, they really know these pumps really well, so you won't be on your own. And when I send Red in the PowerPoint, I'll also send my email and my phone number so you can contact me anytime. Okay? Awesome. Thank you, guys. Yeah?
So how many dialysis patients are on LVADs right now?
For us, 0. I know I was just down at Stanford where they do like 1 million LVADs every day, it seems like, and they said they had implanted an LVAD into a patient who was already on dialysis, which is not something that I can imagine us doing anytime soon, but especially because we are destination therapy and we really want to be mindful of sort of what's a person's quality of life, how much life do they have left, but so we haven't done any. I will say that the first patient that we implanted, I actually wasn't working with this program at the time that this happened, but I know the first patient we implanted immediately after implant, he had a pretty severe AKI, and his creatinine did go up to 5.5, I think. So he didn't require anything, and it dropped down on its own, but it's definitely possible. And we do work with Dr. Amro, is kind of our point person for nephrology, who's really involved with every case, and we have a protocol in terms of what we get for workup, and he sees most patients pre-implant or pre-serious discussion about them.
So is there a place for them to dialyze chronically? Is that been worked out?
That has not been worked out, and that I think is more a question of will than I think we just need to get all the appropriate people in one room to really hammer that out. And I sort of feel like until probably it'll be sort of when the rubber meets the road, then we'll have the discussion, unfortunately. But no, that has not been hammered out quite yet. So, something to look forward to. All right, thank you guys so much.
Thank you.